and the organizers for giving me this opportunity. Now, today's topic is flare-up in endodontics. In this, we'll cover the introduction part, the etiology, prevention and management of flare-ups in dental clinics, precautions to be taken by the dentist, case reports, and conclusion. Flare-up is described as the occurrence of pain, swelling, or the combination of both during the course of root canal treatment, which results in unscheduled visit by the patient to the dental clinic. Pain may occur soon after initiating the root canal treatment for an asymptomatic necrotic tooth or shortly after the initial emergency treatment or during the course of treatment. American Association of Endodontists defined this condition as an acute exacerbation of periradicular pathology after initiation or in continuation of the root canal treatment. So basically, this is a worrisome and painful situation for both the patient as well as for the dentist. The mid-treatment flare-up is a true emergency, and it is so severe that an unscheduled patient visit and treatment is required. Despite the judicious and careful treatment procedure, complications such as pain, swelling, or both may occur. The inter-appointment emergency are undesirable and disruptive events, so it should be resorted as soon as possible. Basically, when the inflammation occur or the flare-up occur, the acute periapical inflammation is the most common cause of this mid-treatment pain and swelling experienced by the patient. The mid-treatment emergencies are usually due to irritant left within the root canal system or iatrogenic factors such as operator's fault and host factor. The occurrence of mild pain is common, but the severe pain and swelling associated with flare-up has a higher incidence of 1.4 to 16%. Coming to the etiology of flare-up, it is basically multifactorial. As we can see, the causes of flare-up in endodontics is due to three factors, that is chemical injury to the tissue, microbial injury, that is bacterial cause, and the mechanical injury to the pulpal tissue. Most of the flare-ups occur as a result of acute periradicular inflammation secondary to the root canal. As we know, the apical periodontitis secondary to the root canal treatment is basically due to over-instrumentation or over-extrusion of the irrigants we use in RCT. The over-instrumentation, when your instrument goes beyond the root confines and inflame the periradicular area. Similarly, when we accidentally pushed our irrigants like sodium hypochlorite or other irrigants like chlorhexidine out of the apex, then they cause periapical inflammation, and the body react in a manner as the body considered this foreign object as foreign material, and they start initiation of the inflammatory cell infiltration. When there is an incomplete removal of the pulpal tissue, if while during RCT, if you do not remove complete pulp from the root canal space and there is some necrotic infected pulp left behind, then this is the root cause of the pain and swelling, because the bacteria can regrow, multiply, and spread the inflammation. The incomplete chemomechanical preparation-induced changes in the root canal system, which may favor the outgrowth of or overgrowth of the certain species. And when the virulence and the pathogenicity of these bacteria, which is remaining behind in the root canal, overgrows and supersedes the host immune response, then they cause imbalance and periradicular pathology, which will ultimately result in the inflammation, pain, and swelling. Recrudescence of the chronic apical periodontitis or phoenic sepsis. It is a condition that occurs in teeth with necrotic pulp, apical lesions that are asymptomatic. There is no exacerbation of the previously symptomless periradicular lesion, and it is mainly due to alteration of the internal environment of root canal space, and the general clinical sign and symptoms will be mobility, tenderness, and swelling. Overfilling. Overextended obturation and overfilling means the obturation which goes beyond the root confines, and this will be taken as the foreign body reaction by the body, and there will be biofilm accumulation on this extruded part of the obturation or sealer, and then there is the chronic cell infiltration like plasma cells, polymorphonuclear leukocytes or neutrophils, and there will be activation of the complement system, leukotrienes, which will ultimately experienced by the patient as pain and swelling. Then the other cause is periapical lesion. As we know that when there is caries and the infection is spread to the root canal, it will grow in the root canal, and once the infection is spread beyond the apex, it will spread into the periradicular area, cause periradicular inflammation, and this will ultimately result in abscess. In retreatment cases, the flare-ups are very much common. In these cases, the host response to the extruded filling material and toxic solvent may increase the pain. The host factor will also plays a part in causation of the flare-ups. The intensity of the preoperative pain and the amount of patient apprehension are correlated to degree of post-operative pain. Basically, the host factor includes the decreased host immunity. If the patient is suffering from systemic disease like diabetes, the patient is having a poor medical status, and if the patient is taking immunosuppressant drug, then the chances of flare-ups are very high. Coming to epidemiology and immunology of flare-ups, there are 7 factors which are responsible for flare-ups. They are the alteration of the local adaptation syndrome, changes in periapical tissue pressure, microbial factors, chemical mediator or cells of inflammation, change in the cyclic nucleotides, immunological response, and psychological factor of the patient. There is the first is alteration of the local adaptation syndrome. Saleh has shown that when a new irritant in the form of irrigant is introduced in a chronically inflamed tissue, a violent reaction may occur in the root canal system because of the disturbance in the local tissue adaptation. For example, in case of chronic pulpal disease, the inflammatory lesion is adapted to the irritant, but during root canal therapy, a new irrigant in the form of medicament get introduced, and the bacteria will take it as a weapon used against it. So what the bacteria will do, the bacteria will release leukotrienes, the bacteria will stimulate and triggers the inflammatory cells, the bacteria will release various type of proteolytic enzymes such as collagenase, fibrinolase, elastase, and toxins, which will induce and trigger the inflammatory cells. Now coming to the microbial factors, bacteria are the main causative factor in the pulpal and periapical disease. Studies have shown that enzymes, endotoxins, and other chemicals produced by microorganism may cause inflammation and persistence of periapical lesion. The most commonly found anaerobe in case of flare-up is bacteroides melanogenicus. So how does this they release proteolytic enzymes whenever we start root canal treatment. As you know, we have to do instrumentation or filing, and then we place certain type of irrigants. These irrigants and instrumentation disrupts the local system of the root canal, and various microorganism will evolve, and these microorganism releases proteolytic enzymes such as collagenase, fibrinolase, and endotoxins, and they stimulate the complement system and the inflammatory cells like Hagman factor, which will release the pain mediators and bradykinin. In case of this inflammation of flare-up, the pain mediators, there are various substances like substance P, bradykinin, activating factor, which can cause the pain. Now, they also stimulate the chemical mediators in our body. There are 2 types of chemical mediators of inflammation. One is the cell mediator released by the cells, and one is plasma mediator, which is present in the blood. The cell mediator includes the histamine, serotonin, prostaglandin, platelet activating factor, and lysosomal components, whereas the plasma mediator present in the body in inactive form. But when the bacteria releases toxins and proteolytic enzyme, they get triggered, and then they release bradykinin and leukotrienes. All these factors will cause pain and swelling in the patient. Effect of chemical mediators. The chemical mediator can be in the form of cell mediator, plasma mediator, as I have told you earlier, and in the form of neutrophils. So whenever there is an irritation or inflammation of the tissue, the cell membrane and the blood vessels, they release arachidonic acid derivatives, histamine, and this cause the Hagman factor to stimulate and trigger, and then they cause inflammation. Changes in the cyclic nucleotide. Now this is again a new mechanism which have been shown by various literature, that there is increase in the cyclic adenosine monophosphate, which inhibits the mast cell granulation, decreases the pain. But in case of flare-up, there is an increase in CGMP, stimulates the mast cell granulation, release of the histamine, prostaglandin, which are pain-producing substance. So this is the mechanism. The mast cell on degranulation due to tissue injury, immune activation, chemical irritant, and medicament causes degranulation of the mast cell, and they cause the release of histamines, prostaglandins, leukotrienes, and various chemotactic factors which cause the pain. Immunological response in chronic pulpitis and periapical disease, presence of the MACTs lymphocyte indicate both cell-mediated and humoral response. Psychological factor, this is basically patient dependent. The anxiety of the patient, apprehension of the patient, fear of the patient towards dental treatment, and previous history of traumatic dental experience appear to play an important role in mid-treatment flare-ups. So this is the summary of the mechanism of flare-ups, basically the etiology of the flare-up. Whenever there is an injury to the tissue in the root canal, there is disruption of the microbial community, and various microorganisms which are very virulent and most potent, they cause release of the toxins, they cause host cell destruction. These will cause the inflammation to appear, and then the inflammatory cells comes into role and they cause pain and swelling. Now, we have discussed about the various etiological factors. Now coming to the crux of the story. But before going into this crux of the story, I would like to ask one question. Suppose you all are staying in your house, right? Some stranger comes one day and tries to throw you out of your house. What will you do? Will you surrender or will you fight back? Or will you retaliate to that force? Obviously, the answer is you will retaliate. You will protest. Same story goes here. The crux of the story is when, as a human, we want to remove the bacteria from the root canal space so that there won't be any pain or inflammation or flare up. How do we do this? We will do root canal opening, axis opening. We do the CMP, chemomechanical preparation, instrumentation, and then we place various endodontic irrigant like sodium hypochlorite, chlorhexidine, hydrogen peroxide, and various other materials. And we also use intracanal medicament in the form of chlorophenol or calcium hydroxide in the canal. So we as humans want to protect our space, that is root canal space, from the bacteria. But the bacteria has already gained the entry into the root canal and it stays there. So when we are introducing all these materials into the root canal to remove the bacteria fights back by releasing the toxins, by releasing the proteolytic enzyme. As I have told you, they are collagenase, fibrinolase, and elastase. They cause host cell destruction, and the bacterial toxins trigger the inflammatory cells like cell and plasma mediator, which I have told you earlier. All these factors will increase the inflammatory extrude, and this spread of inflammation and infection cause the pain and swelling. So this is the crux of the story of this flare-up. Now coming to the diagnosis and management, establishing the cause of flare-up is an important step towards management of mid-treatment pain. It is necessary to warn the patient that he or she may experience slight pain after the appointment. So analgesics should be prescribed always when patient experience moderate to severe pain after the first appointment. Inter-appointment emergency are divided into patient with an initial diagnosis of a vital or non-vital tooth with or without swelling. So in first condition, that is previously vital pulp with complete debridement. In these conditions, the chance of flare-ups are very less. Only patient reassurance and the prescription of mild to moderate analgesics often will do the job. In case of previously vital pulp with incomplete debridement of the root canal system, it is most commonly seen that pulp remnant left during debridement considered to be a major irritant causing severe pain to the patient. To manage this condition, the working length should be rechecked and the canals should be carefully cleaned with copious irrigation of endodontic irrigants like sodium hypochlorite, and then a dry cotton pellet is placed, followed by a temporary film, and a mild analgesic is prescribed. Previously necrotic pulp without swelling, studies have shown that incidence of flare-up is higher with necrotic pulp than in the vital. The teeth with necrotic pulp often develop as acute apical abscess after the initial appointment. As the lesion is confined to bone, there occurs the severe pain. So the best method of managing the necrotic pulp is to establish a proper working length, which is a very mandatory step in case of root canal treatment. We should do complete debridement of the root canal by instrumentation and copious irrigation along with the intracanal medicament. In this case, the tooth is opened and the canal is gently re-cleaned and irrigated with copious amount of irrigants, and drainage must be established as soon as possible. In case of previously necrotic pulp present with swelling, these cases are best managed by incision and drainage. Also, the canal should be opened, debrided, and gently irrigated with hydroxide dressing and closed. Now coming to the general management of flare-ups. Studies have shown that post-operative pain diminishes in 72 hours, that is 3 days. During this, patient experience pain, which must be relieved by the clinician. So the general management of the flare-up includes the reassurance to the patient, complete debridement, chemomechanical preparation of the root canal system so that we should not leave any bacteria behind, establishment of the drainage if there is any pus or suppuration, relief of occlusion, that is, we have to deocclude the tooth from occlusion, calcium hydroxide therapy, intracanal medicaments, medication, which includes mostly the analgesics, antibiotics, and corticosteroids, and then the placebo. Coming to the first one, the management of flare-ups, that is reassurance to the patient. Reassurance is the most important aspect of the treatment in case of flare-ups. So explain the patient about each and every step. You have to tell that flare-up is a common condition which could be resolved. General anesthesia, conscious sedation are also helpful adjunct in treating some cases, especially in case of uncooperative and fearful patients. Second is the complete debridement of the root canal system. As you know, whenever there is an infection in our body, we have to completely remove the root cause of the infection. In case of teeth, we have to do the complete debridement, cleaning and shaping of the root canal system. Single most effective method to reduce the flare-up is the complete debridement. Patency of the apex, shaping and cleaning by crown down technique are the two most important factors which you should keep in mind during the management of flare-ups. Establishment of the drainage of pus. In the presence of pus or suppuration, drainage of exudate is the most effective method for reducing pain and swelling of the patient. In most cases, accumulated exudate will surge from root canal, affording immediate relief. But in some cases, root canal instruments are needed to pass through pegged dentinal shaving in the apical third of canal. Fourth is the relief of occlusion. In case of chronically inflamed tooth present with the flare-up, we have to deocclude the tooth so that it should not come into contact with the antagonist tooth. Why we do deocclusion? We do this procedure because whenever there is a flare-up and there is a periradicular inflammation in sign of swelling or pain, if we do not deocclude the tooth will directly come into contact whenever the patient masticates. So there will be a constant pressure, and due to this pressure, there will be increase in intrapulpal pressure, and already there is a infection present. So all these factors will cause severe pain and swelling to the patient. So we have to deocclude it so that the tooth should be free from any masticatory pressure. Then we can place calcium hydroxide therapy. It reduces the bacterial colony and their toxic byproduct. The calcium hydroxide antimicrobial effect remains in canal for about 1 week. Now coming to the mechanism of calcium hydroxide, how is it helpful in case of flare-ups? Calcium hydroxide dissociates and forms calcium, releases calcium and hydroxyl ions, which is a high pH. This high pH of about 12 is having a detrimental effect on the bacterial cell. It causes disruption of the bacterial cell and killing of the microorganism. This calcium hydroxide also absorbs carbon dioxide because, as we know, in case of root canal infection, the environment in the root canal is mostly anaerobic and there is a production of carbon dioxide by the bacteria. So calcium hydroxide helps in the absorption of carbon dioxide, and this absorption of carbon dioxide kills the bacteria present in the root canal. Then it also causes protein denaturation or bacterial cell death. And when we place the calcium hydroxide into the canal, it obliterates the root canal space and leaves no space or minimal space for any bacterial growth. So this is the mechanism of calcium hydroxide in case of flare-up. For relief of pain during root canal treatment, commonly used intracanal medicaments are antimicrobial agent, irrigating solution, and corticosteroids. The corticosteroids we use in case of root canal treatment in intracanal, these inhibit the formation of arachidonic acid, and therefore it will lead to inhibition of the prostaglandin synthesis. Now we should keep in mind that the production of prostaglandin produces pain in our body. So inhibition of prostaglandin is very much essential if we do not want any pain. Secondly, the corticosteroid increases the CAMP levels in the body, which inhibits the mast cell degranulation, and thereby it inhibits the histamine release, and it inhibits or stops the inflammation, pain, and swelling. Seventh point is the medication. This is very important because we have to prescribe antibiotics, analgesics in case of flare-ups for sure. So commonly used systemic drugs are analgesics, antibiotics, corticosteroids. These are antibiotics which we have to give in case of flare-up, that is amoxicillin plus clavulanic acid salt or combination. Moxclav, this is the commercial antibiotic available in the dose of 625 milligram BD for 5 days. That means twice a day for 5 days. Then the second is metronidazole or flagyl 400 mg. This we have to give for TID dose for 5 days. So basically, Moxclav 25, it is a broad spectrum antibiotic. It works specifically or predominantly for the gram-positive microorganism, whereas metronidazole, it acts mainly for the against the anaerobic microorganism. And non-steroidal anti-inflammatory drugs are commonly used for relieving the pain. Commonly used drugs are ibuprofen, how these NSAIDs, work against inflammation. They inhibit the prostaglandin synthesis, and various type of NSAIDs are ketorolac, diclofenac sodium, ibuprofen, which you can give in case of flare-up. So these are the photographs of some of the NSAIDs available. Ketorol TT, which contains ketorolac 10 milligram, diclofenac sodium you can give in the dose of 50 or 100 mg, and Gerodol SP, which contains acylofenac 100 mg, paracetamol 25 mg, and serratiopeptidase 15 mg. This serratiopeptidase will cause the connective tissue breakdown, and it helps in relieving of any kind of swelling. So these are very important NSAIDs which you can prescribe to the patient. Then there are other narcotic analgesics which we can give in case of severe pain where the patient cannot tolerate the pain. They basically act by relieving the central nervous system, or they act on the central nervous system directly. And the example of narcotic analgesics are meperidine, tramadol, propoxyphene. These are the clinical photograph of tramadol and diclofenac sodium in combination. Now, the 8th point is placebo. Placebos are the pharmacologically inert substance which do any therapeutic effect. They act as analgesics and alleviates anxiety. They mimic the action of active drugs. Studies have shown that patients experience the relief of pain after receiving the placebo. The placebo effect are based on the patient comprehension and psychological response to the drug administration. In case of placebo, as I told you, they are not reactive or pharmacologically inert substance. They do not have any therapeutic effect. But when we tell the patient that they will act on the body and then they will relieve the pain, the patient, here we have the patient psychology in removing the pain. So or they are going for acupuncture. What's the basic mechanism? How do these they actually psychological patient? It is well known that in a happy mood there are certain substances, no endorphins, which are pain alleviating or pain relieving substances. So when we give the assurance and when we give the placebo drugs to patient, they think that these drugs will act faster and the pain will go. And ultimately, this will happen also because the psychological dependence of the patient on the clinician. So clinician exerts a potent placebo effect. His conviction that an analgesic is effective, if communicated to the anxious patient, increase the expectation of patient relief. Also, instruction or suggestion given to patient are powerful help in controlling the pain. Placebo enhances the level of endorphins, thus resulting in relief. Coming to the preventive measures to infectious flare-up in our clinical setup, selection of instrumentation technique that extrude less amount of necrotic debris from the apex, completion of chemomechanical preparation in a single visit, use of antimicrobial intracanal irrigants and intracanal medicaments. We should not leave the tooth open, or we should not give open dressing, because it can cause reinfection or re-entry of the microorganism into a previously cleaned canal. Maintaining the aseptic chain, as you know, sterilization of the instruments is very essential. Application of rubber dam during root canal treatment is a very critical step in preventing any kind of cross contamination and infection. So selection of instrumentation technique that extrude less amount of debris apically, we should use crown down technique, which will cause lesser amount of debris extrusion beyond the apex, and this will result in minimal or no inflammation in the periradicular area. Irrigation, we should use copious amount of irrigation whenever we are doing root canal treatment. This will help in complete debridement of the root canal, necrotic tissue and microorganisms. Not leave the teeth open for drainage. To leave the tooth open is the most direct way to permit reinfection of the root canal system, in addition to any previous attempt. If the tooth is left open, more microbial cells, toxic products and substrate are allowed to gain access to the root canal. Maintain asepsis. The clinician should be aware of need to perform endodontic treatment at strict aseptic condition. So rubber dam is mandatory whenever we are doing root canal treatment. Now, in case of swelling and severe pain, the most radical treatment of flare-up is, if there is a swelling in the vestibular area of the patient, we have to go for incision and drainage. With the help of PP blade, we can give an incision on the most dependent or the most fluctuant part of the swelling. Once we do this incision, the pus will comes out, the pus will drain, and then we have to apply the rubber drain, and then we can suture this rubber drain in the vestibular region. This will help in instant relief of the pain and swelling, and then we can proceed with our general root canal treatment by access opening and further treatment. Now, this is a case report. As you can see, there is a swelling present in the first molar right region of the jaw, and the swelling extend to the area below the eyes. You can see the radiographic picture of infected first molar, and this is the clinical photograph of the infected first molar. Then this is the post-operative pictures and radiograph. As you can see, after negotiation of 4 canals in this tooth, there is MB2 canal also there. So we have to negotiate all the canals. We have to do the working length determination, cleaning and shaping, complete debridement, and copious irrigation. And once the operation is done, we have to give the coronal seal, as we can see in this radiograph. And as we can see, this is the 7th day post-operative photograph where the extraoral swelling has subsided. So you can compare the pre-operative pictures and the post-operative picture. This is a typical case of flare-up, because in case of flare-up, once the infection goes out of the root canal, it will spread into the periradicular area, and then it will spread to the other regions of the face. So, points to remember while we're doing the management of flare-up is, we have to maintain asepsis. Sterilization and rubber dam is very much essential. Reduce the tooth from occlusion so that it won't feel any pressure. Determination of the correct working length, then followed by complete extraction of the is complete removal of the necrotic or infected pulp, bacteria and their byproducts, their toxins. We can place intra-ligaments, and we have to give analgesic and antibiotic to the patient. So coming to the conclusion, the occurrence of the mild pain and discomfort is common. Even treatment remedies still psychological preparation of the patient, complete cleaning and shape, use of anesthetic analgesics decrease the incidence of flare-up in mild to moderate level. Prompt and effective treatment of flare-up is an essential of overall endodontic treatment. These are my references. So I concluded, and thank you all for listening.
Thank you, sir. It was a very informative session. I've learned a lot of things, especially the management aspects. So it was truly a very enlightening session. Thank you, sir.
And is there any
So in the chat session, there's one question from Himadri. She's asking what we have to do if there is a severe or moderate pain during RCT, especially in the step of BMP.
Okay. This is a common problem which can be encountered daily or on a routine basis. When there is a pain during BMP, first we have to check that tooth should be removed from occlusion. We have to do the deocclusion process. Then we have to search for all the canals, any missed canal. Here we have to go for CBCT in case if there is a suspicion of the MB2 canals or canal of radix and molaris. Then we have to do the complete debridement with help of proteins. We have to regularly use the copious amount of irrigation. This sounds very simple, but this irrigation of root canal treatment, it is very important having root canal because it will flush out all the necrotic debris, microorganism, their byproducts, and the dead dentinal shavings out of the canal. So after that, we can prescribe antibiotics. If the patient is complaining of pain, we can give the antibiotics and analgesics along with the CMP, that is chemomechanical preparation.
So the second question is from Ananya. She's asking how to anesthetize hot tooth, sir.
As we know, in case of hot tooth, the patient so INAB block if it is lower molar or if it is lower tooth, then we can give inferior alveolar nerve block, and then we can also give anesthesia as intrapulpal or in the form of intraligamentary anesthesia. Intrapulpal anesthesia, the third question also comes that can we give LA directly in canal? Yes, you can give LA directly into the canal. For that intrapulpal anesthesia, what you have to do when there is a hot tooth or the patient is complaining of severe pain even after giving block, we have to give intrapulpal anesthesia. In this technique, you have to load the syringe, then you have to bend the syringe slightly and you have to wedge the syringe inside the root canal orifice, and then with slight pressure you have to give it. Basically, it is not necessary that only LA we can give saline, we can use saline also, because when we are giving intrapulpal anesthesia, actually we are decompressing the nerves by applying the pressure. So that's why the wedging of the syringe or needle into the root canal orifice is essential. Then with the help of pressure, we have to introduce our local anesthetic. This will decompress the nerves and then you can have relief from the pain. Any other question, ma'am?
So next question, Himadri is asking, can we give LA directly into the canal?
Yes, I told you, we can give LA directly into the canal only. Even when you are giving the block, it should have. But if the block is also not working, then in case of hot tooth or in case of tooth where there is a pain, you can LA directly into the canal. This is known as intrapulpal anesthesia. This technique is known as intrapulpal anesthesia. You have to introduce LA directly into the canal so that it will anesthetize by pressure anesthesia.
Sir, Himang is asking, is it common to have a positive tendon percussion in the adjacent tooth during the flare-up?
Is it common to have positive TOP in adjacent tooth during flare-up? No, only in case of referred pain. If it is radiating pain or referred pain, then only the patient will feel pain in other tooth. Otherwise, the tooth inflamed, the tooth which is infected, or the tooth in which you are doing canal will have pain.
Sir, actually, there's less than 1 minute. If possible, can we start one more session so that if any other students have a doubts, they can ask?
Okay.
Yes,
you just send me the link, I'll join.
Yes, sir. I request all the other participants, there is a group. I'll keep a link. If you're not able to access it, please give me a text message.